Here. Hello and welcome to our webinar on central sleep apnea and the remedy system. I'd like to thank all of you for joining us today. My name is Diane Canan and I'm a patient educator here at Zoll Respicardia, and I'll be helping our speaker, Dr. Robin Germany, out today. Dr. Germany is a past clinical assistant professor at the University of Oklahoma and the Chief Medical Officer of Zoll Respicardia. She has been with Respicardia for over 15 years and is dual trained in heart failure and electrophysiology. Prior to joining Zoll Respicardia, she was the Director of Heart Failure Treatment and the Medical Director of the Heart, Lung, and Vascular Clinic at the University of Oklahoma. Today, we also have a very special guest joining us, one of our patient ambassadors, Mike Dingledine, who was implanted with the remedy system in January of 2020. He also hosts a patient support group on Facebook. Mike will be sharing his experience with central sleep apnea and the remedy system with you today. This discussion will be followed by a live Q&A where Dr. Germany, Mike, and myself will answer your questions. If you have any questions throughout the presentations, please use the Q&A box to type them in. I will also be available to address questions we are unable to get to after the presentation via email or phone. In the chat, you're going to find the resources mentioned in the presentation and direct links for easy access. And with that, again, we thank you for joining us, and I will turn this over to Dr. Germany to get us started.
Wonderful. Thank you so much, Diane. I appreciate it. And thank you all for joining this today. Is everything showing up okay? Great. So we're going to talk today about sleep apnea, specifically central sleep apnea, and that's how most of you have found your way to this webinar. But sometimes it's nice for some of our attendees that are a little less familiar with the different types of sleep apnea, just to back up a little bit and talk about sleep apnea in general. Sleep apnea is a general term that's used to describe a sleep disorder where patients either stop breathing or have very shallow breathing for at least 10 seconds at a time, at least 5 times an hour. So this is the typical picture of what we would expect to see. Probably, hopefully not you, but friend or neighbor. I always think on the plane, somebody is sleeping with their mouth wide open, and you can imagine this gentleman perhaps waking up with a big snore. I think this is typically what people have a vision of with sleep apnea, because the predominant form of sleep apnea is obstructive sleep apnea. But regardless of which type of sleep apnea you have, each one of these episodes, when you stop breathing, causes a drop in oxygen. So there's a lack of oxygen. You arouse from sleep, so you don't get restful sleep. So the symptoms are fairly similar between the different types of sleep apnea. Oftentimes you might feel like you have just fatigued or a lack of stamina. You don't want to do anything. You might be sleepy. Most people think they have to be very, very sleepy to have sleep apnea. But you can just feel drowsy, falling asleep while driving or while talking to someone. Those are not normal things to happen. Those are very classic symptoms of sleep apnea. You might feel like your brain's in a fog. So especially as some of us get a little bit older, you might think that you're just getting a little less mentally sharp. That can be a sign of sleep apnea. And interestingly enough, having sleep apneas or having a sleep disorder can cause other forms of sleep disorder. So things like insomnia can initially get triggered with sleep apnea, and then likewise sleep apnea can sometimes cause you to release hormones that causes you to not sleep very well. So these are fairly typical signs and symptoms, but people also have a variety of other symptoms that's associated with lack of sleep. Now, I mentioned that there's 2 different types of sleep apnea. We're going to start with obstructive, the kind on the right, because the vast majority of patients with sleep apnea have obstructive sleep apnea. And that's where there is a blockage somewhere in the breathing tube when you go to sleep at night. So during the day, somebody's sitting up, they're awake, all their muscle tone is intact. But when we go to sleep, muscles can get floppy. The tongue can fall back a little bit. Maybe you get a little nasal congestion. All of those things can cause a decrease in the airflow to the lungs. And that causes obstructive sleep apnea. So by definition, something is obstructed. And somewhere around 40% of the adult population has obstructive sleep apnea, depending on which study you read. Central sleep apnea is a very different disease, it is also called sleep apnea, but it's due to the brain failing to send the appropriate signals to the body to breathe. So patients just stop breathing. And over half of patients, there's not a lot of sound associated with it, but some patients will still make some sound at night, oftentimes from the deep breathing, because after you quit breathing, sometimes as long as 45 seconds or even more, your body plays catch up and delivers really big breaths. And sometimes there's sound associated with that. So just because there's sound at night, can't distinguish between obstructive and central, but the timing of when that noise comes can help distinguish between obstructive and central. And we'll talk about how do you tell the difference, how in your own studies, how would you tell the difference? So this is the normal signal that the brain would send. Normally the signals, travel from an area of the brain called the respiratory control center. It's one of the few things in the body that they named with what they actually do. And it sends the signal down one of two nerves, one on each side, called the phrenic nerve. And that tells the breathing muscles to move so that you inhale air. So breathing is actually an active process. So the primary breathing muscle is the diaphragm. So if you take a very deep breath, you'll feel the diaphragm contract right there at the bottom of your rib cage. That's the diaphragm. And when it contracts, it's going to pull air into the lungs and you see the lungs expand. In central sleep apnea, that signal is missing. So the body fails to send the signal down to the diaphragm. Now, each one of these episodes I mentioned earlier can cause what we call hypoxia, or lack of oxygen. On top of that, it causes the body to actually arouse from sleep. So you may not wake up, you may not be aware that you wake up, but with each episode, the body goes to a lighter stage of sleep. So if you can imagine, oftentimes with central sleep apnea, this is happening 30, 40, 50, even more times every hour. So you can imagine it causes a lot of difficulty getting in to that really restful sleep. And that can lead to poor sleep quality, can lead to cognitive issues. Your brain doesn't have enough time to process the memories from the day before. And longer term, you can even get tissue damage from this low oxygen. These changes in oxygen and arousals can actually cause body inflammation. And with each one of these episodes, there's a release of your fight or flight hormones, norepinephrine, adrenaline. With each one, you can actually measure that in the body. And interestingly enough, that's one of the triggers for central sleep apnea. So each episode actually contributes to the development of the next episode. And that's why in central sleep apnea, patients can have hundreds of these episodes every night, because once this process starts, it continues on until either you wake all the way up, you roll from one side to another, something has to change, and then it will kick you out of central sleep apnea. But when you go back to sleep, oftentimes it starts right over again. And because central sleep apnea is related to this fight or flight response, other disorders that have a high release of these same hormones often exist in parallel with central sleep apnea. So the most famous, the one that there's the most data on, is something called heart failure or congestive heart failure. This is a disorder that's associated with very high levels of norepinephrine, and it can actually trigger central sleep apnea to start. However, the long run, because those hormones are actually part of the issue with heart failure, they can actually add additional stress onto the heart, cause scarring to form, cause the heart muscle to actually get weaker. And there's now prospective studies showing that central sleep apnea, if left untreated, can cause both heart failure and other types of cardiac or heart disorders, including atrial fibrillation. But likewise, those disorders can also be the trigger of central sleep apnea. So the important part of this is treating central sleep apnea. Hopefully, we'll find someday that it can actually treat or prevent those. We don't have that data yet, and people are still trying to collect that data. But if you have heart failure or atrial fibrillation or kidney disease, that needs to be treated as well. So both of the disorders need to be treated to prevent worsening of central sleep apnea. So now we know that treating central sleep apnea is important. Central sleep apnea disrupts your sleep, can cause some cardiac issues. So what are we going to do? How do we know if we have central sleep apnea? Well, it all begins with a sleep study. And this is some of the many numbers that occur when you have a sleep study. And I do encourage you to get a copy of your own sleep study report. Some of them are a little simpler than this, especially if you had a home study. But if you had an in-lab study, it may actually have a lot more numbers. However, the numbers that you really need to understand what the disorder that you have are actually very few. They're all in this blue box here. And the first key number is the apnea-hypopnea index. So apnea is the periods of time where you stop breathing, and hypopnea is the period of time where you have shallow breathing. Most physicians think that they have an equal impact. They're both part of the same disorder. So we add all of those together and divide by the amount of time that you're actually sleeping. So for this patient had 272 times during the course of the night that they either had shallow or absent breathing for at least 10 seconds. And divided by the amount of time that they slept, which you can find over here, that means 46.5 times per hour this is happening. So this is the main number, and oftentimes you'll see this recorded in your chart, this AHI number. That tells you how severe the sleep apnea is. Up to 5 in an adult is normal. 5 to 15 is mild. 15 to 30 is moderate. And anything above 30 is considered severe. So this patient has severe sleep apnea. Now, how do we decide if they have obstructive or central? Well, it's right here. And in this report, it's nice because it's right here next to the AHI. And you just look at the numbers of episodes. And this patient has 130 central apneas and 12 obstructive apneas. Therefore, this patient has predominantly central sleep apnea. Okay. Mixed means that it's a little difficult to tell what the cause of that apnea is. And that depends on the laboratory that you're at. But you can see here, even if it got added to the obstructive number, that this patient is going to continue to have predominantly central. Now, the apneas are very easy to tell the difference relatively between obstructive and central. The shallow breaths can be very difficult. And we see now about 10 to 20% of sleep labs are going through and distinguishing whether the hypopneas are obstructive or central. If your sleep report has obstructive and central hypopneas, those are typically added to the apneas in those cases. And then that's how you determine obstructive versus central. But interestingly, in our clinical studies that we're going to talk about here in a little bit, we just use the apneas to distinguish. So if your lab does not classify hypopneas, that is just fine as well. So it's just the technology is getting better where it's getting a little bit easier to distinguish between these hypopneas. So let's talk about the therapy. The therapy we're going to talk about today is the remedē system. There are other therapies that have been used for central sleep apnea. The predominant one are mask-based therapies, and we're not going to cover those a lot today. But if you have some questions about those therapies, feel free to type them into the Q&A button, and we'll try to get to some of those as well. The remedē system is a totally different type of therapy for central sleep apnea. It is indicated for moderate to severe central sleep apnea, which means you would need an AHI of at least 15, only in adults. It does require a sleep study to determine if you're a candidate. The system itself is MR conditional, but it does require a few hoops to go through if you need an MRI. So it's important to tell your physician if that's a request that one of your other physicians makes for you to have. And then there are a number of safety issues that are listed on the website, in the literature. The only contraindication is an active infection at the time of the implant itself, but there are a number of other precautions. So if you have some specific things, you should review those. Those are all able to be found out on the website. So this is the system. The system is called the remedē system. It's a fully implantable system. The device is a neurostimulator, and it has a single lead or a wire that's going to help us restore a normal breathing pattern. This is what the device looks like when it's implanted, as a cartoon anyway. And this lead or wire is placed through a vein, somewhat similar to an IV. The lead is specially designed to go in there, and then it's placed next to one of the two phrenic nerves. So we talked about the phrenic nerves delivering those signals to the diaphragm. Well, this is going to go in, it's going to be placed next to that phrenic nerve to restore the signal so that breathing is maintained. Interestingly, we only need one of the two sides to be stimulated. You don't need a wire on both sides. Because it's placed in a vein, it's not something you would feel in the vein itself. And the nice thing is there are two locations, one on the left and one on the right side, that allow for different anatomies and different patient types. The device itself goes underneath the skin, a little bit below the clavicle. And we'll talk some more about that as well. And so this is a cartoon just basically showing that when the device activates, it's going to deliver that signal to the phrenic nerve, causing the diaphragm to contract. And you can see here that that's going to then pull the air in and restore a natural breathing pattern. Oops. So what does that mean? Well, we talked about the AHI as the number of events per hour. Here you can see patients in a recent clinical trial who were in the severe category overall. You can see that the number of events came down to the mild category at 1 year, and that was maintained out through 5 years. And importantly here, this green is the central apneas. You can see that they're almost resolved. What is left oftentimes are the obstructive events. So if you have a lot of obstructive apneas, it's important to know that this device does not treat that disorder. So, we do see patients sometimes that have a significant amount of obstructive apneas and central apneas. This therapy is not going to treat those obstructive apneas, and you might need an additional therapeutic option for those events. So it's important to have that discussion with your physician about what the plan might be if that number is still above 15 or above 30, especially if you're still feeling fatigued and tired. The shallow breaths can improve some, but again, if they're central hypopneas, these shallow breaths, then those are easier for the device to treat. And this is, again, just a different graphic showing that not only are the central apneas improved, the apnea-hypopnea index is improved, but oxygenation is also improved. And that's maintained out to 5 years. So again, these are numbers. What does that actually, might that mean to you? Well, patients reported, this is a busy slide, but patients reported a significant improvement in daytime sleepiness. Which is a little interesting because central sleep apnea patients often don't necessarily report that they were sleepy during the day. But when you look at them after treatment, they often recognize that they were sleepy and that when they're getting restful sleep, as you can imagine, after you have really good nights of sleep, you are going to feel less sleepy during the day. And the vast majority, 79% of patients said their overall health improved compared to very few patients in the control group. So these patients had the device implanted, but not activated. And then 95% of patients at 1 year said they would go through the therapy again. Now, this is an implantable therapy, so it is important, especially if you have other comorbid conditions, that there are risks associated with this therapy. However, 97% of patients were able to have a successful implantation. 91% of patients were free from serious adverse events, and that those serious adverse events all resolved. So there's typical things that you might see. A couple of patients had an infection that resolved. There was a patient that had an abnormal lab test that required them to stay in the hospital an additional night. Typical things that might happen. Though I would say the number one thing that we see now is that the lead, because these leads are placed, they don't get screwed in. They're placed in a vein. And you do have to be quite careful with your arm for about 6 weeks after. So nothing with really repetitive movement or, for example, golf swings. We're going to want that arm to be below your shoulder for about 6 weeks to give that lead or wire time to heal in. And so that is that can occur in up to 15% of patients. Although hopefully with some better techniques, we'll see those numbers coming down. But that's a piece that you can actually have an active part in, going home, taking it easy for a few weeks. And then importantly, long term, the goal is to get you back to living a full, healthy life where you feel better and you actually feel better to be able to do more things, hopefully, than you were even doing before. So what are the steps if this looks like the right therapy for you? Well, the first thing is you need a sleep study. So if you haven't had one in a year, 2 years, every physician's a little bit different, you may have to go in and have a new sleep study. That's really going to determine if you're a good candidate for the remedy system. And then you would get referred over to a cardiologist to actually have the device implanted. It is an outpatient procedure. Patients typically go home the same day, but if it's a little later in the evening, you might stay overnight. But it's considered an outpatient procedure. There's no general anesthesia. Patients often have what we call conscious sedation. So you'll be nice and restful, but there's no general anesthesia. And when you go home, the device is placed in what we call a monitor mode. So it's going to start collecting data, but it's not actually going to turn on until everything heals. And you'll come back at about 1 month, and that's when into the office, they're going to turn it on. They're going to let you feel it, and they'll program it specifically for you in the office. And then there'll be a few visits in the office to really program and personalize the therapy for you to make sure that it's very comfortable. This can take a period of months. So while some patients feel much better that just that first night it's turned on, it can take a little bit of time to get all the right settings together so that you're feeling restful and can sleep well with the therapy. Let me answer a couple of questions. They may have already made their way to the Q&A button, and I'll remind you here that if you do have questions as we're going through this, please put that into the Q&A box, which is either at the top or the bottom of your screen, and we'll try to get those answered here in a few minutes. So one of the things that I failed to mention earlier is This therapy doesn't have any turn on, turn off button. It's going to automatically turn on at night. And how is it going to do that? Well, I told you that it's going to monitor everything for that first month. And from that, we'll get a really good picture of what time you go to sleep and what time you wake up. So it is only going to come on when it's your programmed time. And maybe we'll talk to Mike here in a little bit to find out kind of how he determined where that time is going to be. And importantly, you also have to be in a sleeping position. So you need to be reclined and not moving. So if you roll from one side to the other, therapy will actually suspend for a short amount of time. If you sit up to go to the restroom, therapy will automatically shut off and come back on when you lay back down. And that's just here you can see the example of that. If you sit up, it's going to shut off. You can go watch TV. Maybe you're out late at night dancing or something. It's not going to come on until you get ready for bed. And then what are the next steps? As we talk here, you say, I would really like to find out maybe some more information. What do I want to do? Well, you can use the Find a Doctor tool. So out on the website, there is a Find a Doctor tool. There's also a little survey that can help you walk through whether or not you might be a candidate for this therapy. So I recommend that. And then again, we always like to point out that while it is approved for MRI, it's called conditional approval, and it does require some special settings. All of those are out and available on the website. So again, you wouldn't need to do necessarily anything for this other than to make sure that your physician knows, because we will actually come in or your physician would turn it off quickly. You'd have the MRI and then turn it back on. So, all right. So with that, I'm going to get to in my mind, the most important part of this webinar. And I am going to stop sharing here. And again, Mike, thank you so much for joining us today. Mike has agreed to share his story about how he found out that he had central sleep apnea and just the process that he's been through. So with that, Mike, I'm going to turn it over to you so that everyone can see and hear your story. Thanks again for joining us.
Well, thank you very much for having me today. I appreciate the opportunity. Good afternoon, everyone. I'm going to start my story back in early 2017. Now, to be honest with you, my problem probably started prior to that. But in 2017, it had reached a point where I could no longer ignore the problem. I didn't know what was going on. I really didn't know what was happening. But what I did know is that I was tired, fatigued. I couldn't sleep. Didn't know what the problem was, and it was it was kind of scary because I would wake up every hour on the hour, if not sooner, and oftentimes be gasping for air, dry mouthed, and I just didn't know what was going on. So I sat down with my wife and I told her what I was experiencing, and we talked about it, and she suggested that I go to the family doctor, tell them my story, and see what suggestions they might have. So I did that. I went in and told them how I was feeling and what was going on in my sleep patterns and everything. And they had two suggestions. And the first suggestion was, let's do some routine blood work. They just wanted to rule out some possibilities of, some other diseases or whatever, and just try to narrow it down a little bit. The other suggestion was to do a sleep study. So I did that. I did this. The blood work came back. Everything looked good. So it wasn't that. So now it must be with the sleep study. So I did the sleep study. And the morning that the technician was politely telling me I could leave, I asked him, I said, so how did I do? Well, he said, you had a few episodes. And I said, well, a few episodes, what exactly does that mean? Well, he said, you have to understand. He said, I'm not at liberty to divulge, any of my findings. He said, I'm just here to collect all the data. I'll pass the information along to your sleep physician. They'll set up an appointment with you, and then they'll go over all that with you. So I did that. And it was about 2 weeks later, I went and I met with my sleep physician. And he proceeded to tell me that I was stopping breathing on an average of 52 times an hour, which obviously by Dr. Germany's numbers, that put me in the severe category. So my question to him was, okay, so what do we do? Well, he said, you know, you have sleep apnea. And he said, I'd like to do the CPAP. And we'll try that out and see how that works. So I got a CPAP machine and they set it up for me and we tried it. And I could never quite understand going into the process how anybody could sleep with something strapped to their head. But knowing that this was supposed to benefit me, I thought, well, I need to try this therapy. So I tried it. Very unsuccessfully, I might add. A few hours into the night, the CPAP machine or the mask usually found itself on the floor and I was trying to sleep. But every night I put it on knowing that this was supposed to be the answer for me. So I did that and went back to my sleep physician and scheduled checkup times. And again, he told me this was not working. We need to make some setting adjustments. So we made some setting adjustments. I changed mask and we proceeded to do this. So I'll fast forward a little bit to the summer of 2019. So now 2.5 years had been going by and I had been struggling with this CPAP therapy, trying to figure out how this was helping me, but it wasn't giving me any relief whatsoever. And I was listening to a radio station and I heard about this device for sleep apnea. And you push this button and turn this on, and this was supposed to help you. Many of you, I'm sure, have already heard of this. It was called Inspire. So I gathered all the information I could about Inspire. I'm in Ohio. I found a doctor at Ohio State that dealt with Inspire. So when I went to my sleep physician, I had all this information ready, but he proceeded to tell me that, again, this was not working. We needed to make some adjustments. And that's when I politely interrupted him and to ask him, I said, can I tell you about something that I heard about? And I proceeded to tell him about Inspire. And he said, I think you'd be a good candidate for that. He said, so if you would like, I'll have my staff send your medical records to this doctor that you found at Ohio State. They'll set up an appointment, and you can go and investigate that therapy. So we did that. And it was October of 2019 when my wife and I went to Ohio State and we met with Dr. Chu. And Dr. Chu introduced himself and he immediately pulled over a whiteboard. And on that whiteboard, he wrote OMC. Well, forgive me, but I don't know what OMC stood for. But he proceeded to tell me, O was for obstructive, he said, and you have 0 obstructive. M is for mixed, and you had 4 mixed. And C is for central, and you had 143 central events. He said, so unfortunately, he said, I can't help you. Inspire is for obstructive sleep apnea, and you're total central. So I'm looking at him and he said, you act like you've never heard this before. I said, well, I haven't. I said, I thought sleep apnea was sleep apnea. Oh, no, he said, there's obstructive and there's central. You're all central. And he said, I can't help you. But the good news is, he said, I have a colleague here at Ohio State, Dr. Agostini, that deals with central sleep apnea. And if you would like, I'll direct my staff to send your information over to Dr. Agostini's office. They'll set up an appointment and you can follow up with them. So I did that. But when I went home, central was a new word in my vocabulary. So I started Googling central. And I don't know if any of you listening today have done that. I would encourage you to do that because I didn't like what I found as far as central sleep apnea. It doesn't go away. It doesn't get better. It progressively gets worse. So I was getting all this information together, and it was early November of 2019. I went to Ohio State. I met with a nurse practitioner by the name of Julie Meese that worked with Dr. Agostini, and Julie proceeded to tell me about central sleep apnea. And she also told me about a device that they used to treat central sleep apnea, which was the remedē system. So in hearing about the remedē system and Julie explaining everything to me, her question was, what do you want to do? I said, well, I said, from what I found out about Central, I didn't like any of it. And I don't see, I can't turn back. I have to go forward. So I think that, I need to look into this. So what do we need to do? And Julie said, well, she said, I think the first step would be to do an in-lab sleep study. She said, your sleep study is about 3 years old. So let's do a sleep study, see if you meet the criteria for the remedy system. So I did that. That was late November of 2019. And I did that. And when they got the results back, it was shown that I was stopping breathing on an average of 57.6 times an hour. So my suspicions were correct in that it was getting worse. From 52 to 57.6. And it was going to continue getting worse if left untreated. So again, her question was, what do you want to do? And again, I wanted to proceed. So she said, well, then we will file your insurance information and we'll see what we get back from them. So they did that. I was on Medicare. They filed with Medicare. I got the answer back in less than 2 weeks. I was approved for the procedure, and they had an opening on January 9th of 2020 if I wanted to proceed with the implant, which I agreed to do. So I went in on that morning, had the implant, pretty remarkable surgery to say the least. As Dr. Germany said, you are lightly sedated, so you're not totally out, you're awake. I had a nurse stationed at my head, and she would occasionally speak to me, give me some directions as far as inhaling, exhaling, holding my breath, and so forth, as they were doing the implant and testing it to make sure everything was fine before they closed it up. So then they took me back to my room and told me that I would have to wait until I could have an x-ray taken to make sure that the lead hadn't moved. And so in the meantime, I had lunch and they gave me some directions. But they also explained to me, as Dr. Germany said, that the device was, even though it wasn't turned on, it was in what they called monitor mode. And it would continue to collect the data as to how I slept, whether I slept on my left side, my right side, or my back, when I went to bed, and just general data as far as my sleep patterns. And then they also told me that I had 3 restrictions that I could not do, even though there was no rehab with this surgery, so to speak, as other surgeries have. I couldn't raise my arm above my shoulder for a period of 4 to 6 weeks, or until I was activated, which was supposedly 4 to 6 weeks. The second restriction was that I was not able to lift anything greater than 10 pounds with my right arm. And they equated that to a full gallon of milk. Okay, not a big deal. And the third restriction was that if I went into a business or whatever that you had to push or pull a door, I was not able to, I wasn't supposed to use any force greater than 10 pounds to push or pull that door. So basically, use your left arm, have somebody do it for you, but basically, put your right arm and your right hand in your pocket and take it easy. Just relax, and they wanted to give that lead time to heal in properly so that it didn't dislodge. So I did that. I went back at 6 weeks for my activation. And at that time, Julie looked at my site and said that I was released. I could do anything that I was previously doing. So I could reach for things. I could do whatever. And I met with Julie, 2 technicians from Respicardia, and the area rep from Respicardia was present as well. And we talked about the procedure. They downloaded the data that it had been collecting, which we discussed, and they proceeded to set the 3 settings, left, right, and back, for the proper setting. So we did that. I went home, and knowing that night it was going to turn on, my window was 11 to 7, that the device would turn on at 11 o'clock, based on the fact that I was in my sleeping position and I was motionless for the programmed amount of time. So I was a little bit apprehensive as to what I would actually feel, even though I felt it in the office, Now I was going to be on my own, laying in bed, feeling this sensation, and I was just a little curious. So I had been introduced to another patient ambassador, and I called Sean and I asked him, I said, so what can I expect? And Sean said, well, what time's your device supposed to turn on? I said, well, it's programmed to turn on at 11 o'clock. He said, well, my advice to you would be just go to sleep about 10:30, 20 till 11 and see what happens. Okay, moment of silence. I'm waiting on more instruction, but he gave me none. But in retrospect, it was probably the best advice he could have given me because I did that. I never felt the device turn on the first night. In fact, the very first night, I slept through my entire window. I didn't wake up till after 7 a.m. in the morning. Now, that's not always the case, being for two reasons. One is I'm of the age where I often need to use the restroom through the night. I hate to admit that, but it's a fact. And so if that's the case, my body wakes me up. The device pauses therapy. I get up, I go use the restroom, get a drink, do whatever I have to do, go back to bed. Once I'm in bed and remain motionless for the programmed amount of time, the device will turn back on. I'm also a diabetic. So if my blood sugar drops, my body will wake me up. Again, the device will pause therapy, allow me to get up and go address that. And when I go back to bed, I'm able to go back to sleep. So I did this with the understanding that my device, my settings were going to ramp up periodically every week. They were going to increase incrementally for a period of 6 weeks. And at 6 weeks, I was to go back, which I did. And they downloaded the data again, made some further adjustments, and sent me home. I was supposed to go back in 3 months. So at 3 months, I went back and I told Julie, I said, I'm feeling a little bit better. I said, I'm sleeping now and I'm starting to feel, more rested and so forth. And, so that was good. And she downloaded the data. We made another adjustment and I went on my way knowing I was supposed to come back in 3 months. So at 6 months, when I went back, again, I told Julie, I said, I'm feeling better. I said, I'm sleeping, I have more energy. And, I'm really noticing a difference. And she thought then that was good. And so she scheduled a sleep study for September of 20. And I did the sleep study. And my only concern at that time was it better than the last one? I don't know my numbers. She never told me. And she told me was, even though I had shown improvement, it was not where she wanted me to be, that I could do even better, that they could get me, better numbers and so forth. So we continued to make adjustments every 3 months. And in July of 21, they made an adjustment and scheduled a sleep study for August of 21. And at that time, after my sleep study came back, my AHI, which was at 57.6, prior to getting the remedē system, was now at 4.3. And my central events were 0. And I'm happy to say that we've not made a further adjustment to my device settings since that time. So it's been 3 years now, and I've had no further adjustments. I was just back there last month for a checkup. I go every 9 months, and they made no further adjustments. And my window is shortened up to 7.5 hours. I told Julie earlier on that I wanted to stay up a little bit later, that I was feeling better. So she shortened my window from 11:30 to 7. And so it's showing that out of my 7.5 possible hours of therapy, I'm getting about 7.15 hours of therapy. So during the night, if I roll over, the device pauses and then restarts again. If I have to get up, it stops and starts again. But really, 7.15 out of 7.5 is pretty good. Anybody that's listening, if you got 7 hours of sleep, non-interrupted sleep, you'd be very happy with that, and I am. And so the remedē system has restored a quality of life that at one time I had wondered if I would ever get back to again. It is giving me a second chance. I have more energy. I have a will and a desire to do more things, to get out, to be a little bit more active and so forth. And it's been a good journey. And I I can assure you that if you decide to go that route, that it will do things for you as well. So I appreciate you listening to my story. Thank you.
Thank you so much, Mike. It's always powerful to hear, and the fact that much of this was going on during COVID, which you which made some of the follow-up a little bit interesting as well. You were quite the trooper during that time point. So thanks so much for sharing with us. And Diana, it looks like we may have some questions.
Oh, we do.
today.
We have some really good ones. I'm excited. And yes, and thanks so much, both Mike and you, Dr. Germany. We're gonna just start kind of going through these questions. I'm gonna try and combine a few of them. This first two is what triggers the device to send the pulse? And does that device send a pulse all of the time? Or does it sense when I'm not breathing? And that's a question we do get a lot from some of our patients.
No, it's a great question. So interestingly enough, we actually have the ability to do either. There is a mode in the device that will allow it to sense and only stimulate when you stop breathing. But interestingly enough, it does not work as well as stimulating at a set rate throughout the night. That by stimulating at a set rate, which is typically a little bit slower respiratory rate, like you might have when you go to sleep at night. And Mike, you might know your respiratory rate. But that is actually a much better way to keep you out of central sleep apnea, because your body wants to go into this to this breathing pattern where it stops breathing. And if we just stimulate when you quit breathing, then we're constantly playing catch up. And so what we want to do is actually prevent you from ever going in these sleep apnea. So it typically does come on at the beginning of the night. It's going to stimulate at a constant rate, and it'll shut off in the morning. Mike, I don't know if you want to add to that.
I breathe 14 times a minute, and I don't know much about starting and stopping all those times. I would be a little bit apprehensive about that. In my rate, if I'm stopping breathing 57.6 times an hour, that means the device has to start and stop 57.6 times an hour. And I would be, if I stop breathing, then it has to kick on. What I like about the fact is that I know that it is working. I know that I'm not going to stop breathing. So once the device starts during that hour, when it starts, it is breathing for me 14 times an hour. And it's allowing me to, it takes that, the feeling away that you're going to stop breathing. It's a scary thought when you think about that. And so I no longer have to be concerned with that.
All right, thank you both. The next question, does the wire, that lead, interfere with blood flow in the vein that it's placed or cause any problems such as clotting?
Yeah, that's a great question. I don't think we've ever been asked that question before, which is kind of surprising to me. It is a question we get up from a lot of physicians. So it does depend a little bit on which lead is placed. So the lead that is placed on the left side goes into a very, very small vein. And there's a lot of other small veins in that area. And so it could impede blood flow to this little tiny vein, but the body just is able to work around it, and the blood goes into other veins. So it's not been a problem. It's typically one, if you were to ever have surgery, they often will actually clip this vein, which sometimes makes it difficult if you've had multiple open heart surgeries or something to find this vein, because oftentimes they'll just clip it off. If it's placed on the right side or the bigger vessels, it is a very unusual thing for clots to form, but it can happen. Any kind of pacemaker wire, anything in the vein can occasionally cause a clot. We have a very, very low rate. We did not have any in the clinical trial, but it can happen. And usually that's treated with at least short-term, some blood thinners for a short period of time. But again, we're talking, less than 0.5% of the time that this happens.
All right, thank you. Next question, I've never been asked this question, but it is interesting. What is the worst complication that's ever happened with Remedy, either during implant, or even post-implant?
Yeah, that's a great question. I would say probably the one that happens the most often that requires a second procedure is that wire moving. So you heard both Mike and I talk about that and the importance, because it requires you to go back and have the lead placed again. So to me, having to go back in for something that's that's always a big deal. Things we haven't seen, but there is some sedation. So, anytime you have sedation, that can, cause some airway issues that we've never seen it. We have over 1,000 patients commercially and close to 300 patients in trials. But with any procedure, anytime you have anesthesia, right, there is always a risk that you would react poorly to the anesthesia. Thankfully, we haven't seen that yet. We've not had any deaths, for example. I think that's what scares everybody, right? We've not had any deaths associated with placement of the device or anything like that. And we have had a couple of infections. And typically, if the device itself gets infected, that requires at least temporary removal.
Okay, thank you. Another very common question that the patient educators get is the recovery process, the restrictions involved after implant. Can you speak to that? Any restrictions or activities they should avoid?
Well, I think Mike covered that pretty well. He went through his restrictions, but the main thing, as he said, is keeping that arm until it's healed in. And healing time can be a little bit different from one person to another. So listening to your doctor, making sure that, you're not going out lifting weights, baling hay, mopping the garage. These are all real things that we've had patients go home and do, the first couple of days after the procedure. So really, taking care of that arm. And then once you're released, then you should be able to go back to all your regular activities. So there shouldn't be a lot of restrictions long term.
Okay. I'm gonna go off list here and just ask, a lot of patients are always asking us, how big is this device and what does it feel like? Mike, I know you're really good to speaking to that and explaining that.
And then Diane, after that, remind me, because I want to go back and clarify one thing I said. Go ahead, Mike.
Nope, go ahead. You can.
Yeah, go ahead.
So I was just thinking about, because I don't know who asked this. So we talked about restrictions, but there are a few like very specific restrictions that are out in the patient brochure. So and I will give you some examples. There's something called diathermy. If you don't know what it is, you don't use it. I've never known anybody that's had it, but it's a special kind of physical therapy. Welding, specifically TIG welding. I'm not a welder, but my son does TIG welding. So,
Okay.
And then if you shoot a gun, then you do, especially rifles. If you're a hunter, make sure you tell your physician ahead of time, because that may have to do with where they place the device.
Okay.
Okay, sorry.
Great. No, great. That's great information. Thank you, Dr. Germany.
Okay, you asked me about the size of the device. Obviously, the device is relatively small, and in fact, the newest device is the smallest device out there. I had the original device on my initial implant, which was a little bit, larger than the other one, but it was still relatively small. People often ask, can you see it? Can you feel it? And there, it's a valid question. I can understand their concerns for that, but I reassure them that really it is not so, it's not much. We refer to it as a battery. And oftentimes people, in their imaginations, they think of a battery being a larger device, but it's not. It's not obtruse. It doesn't, it doesn't stick out much or anything. It kind of depends upon your physique. There is a slight bump there, but it's small, and it's not too much. But one of the things that I like is when I speak to people prior to getting the device and they ask about that. And then when I speak to them after they've gotten it, they admit to me that it was really not much of a concern, because now that they have it, they see that it's really not very noticeable. And you would never see it through clothing or anything like that. It just doesn't stick out.
Great. I just wanted to show folks, this is actually one of the devices itself. It's a little different color than what it normally comes in, but if you can see it in the palm of my hand, I just wanted to kind of show you that. So similar in size, just where it is in the palm of my hand. Okay, we're going to keep going with some questions. Thank you, Mike. Next question, what is the relation to CSA and AFib? And can repetitive low heart rates from AFib, such as 30 beats per minute, show up as apnea on a sleep study?
So no, it wouldn't show up as an apnea. Actually, the apnea itself can cause the low heart rate. So actually, if you have a heart monitor, one of the ways to pick up sleep apnea on a heart monitor is you'll often see the heart rate go down very low. Patients can actually have 2-second pauses, sometimes with long apneas. So as breath is not moving, the heart rate actually slows down to compensate for that, and then it'll speed back up. So you'll often see episodes where the heart rate goes way down and then the heart rate picks back up. So in the very beginning, we talked about the relationship between heart failure and central sleep apnea. You can just replace that with atrial fibrillation. So atrial fibrillation is associated with high levels of hormones that can trigger central sleep apnea. But there's also data out there showing that if you have central sleep apnea over years, it can, again, probably because of the hypoxia and these surges of norepinephrine, can actually be the trigger for atrial fibrillation. It's related to that, to new onset atrial fibrillation. So it's really important that you treat both, but they do need separate therapies.
That's great information, Dr. Germany. Thank you. Next question, we'll kind of roll into any issues with having remedē along with a BiV pacer. We do get this question quite frequently, have patients who have other devices. So hopefully you could speak to that for our patients.
So I always tell people that's how I got here is we knew that about 40 to 50% of our patients would likely have a pacemaker or a defibrillator or biventricular pacemaker. And in the clinical study, 42% of patients had another device. So there's a testing protocol. And anytime you have either the devices, any kind of surgical procedure with those, you need to make sure both the physicians know. But it's actually put in by the same physicians that put in your biventricular pacer. It may not be the exact same physician, but the same type. And they're designed to work very well together. Again, just may need a little bit of programming changes, mainly because all of these technologies continue to get better. And so we always want to make sure that we're testing with the actual device that you have implanted. But all the companies are good to work with. We have all kinds of devices. We've had deep brain stimulators. We've had pain neurostimulators. So again, just important to talk to your doctor so that they know, and we can do whatever testing's needed.
I'm going to try and combine two of these questions for the next ones. Thank you, Dr. Germany. This patient typed in, for the patient with both OSA and CSA, is there a treatment for OSA that can work in conjunction with remedē? And I'm going to combine that with the question where someone wrote in, what percentages of people have both Inspire and remedē? And I know you did speak to that, but these are questions that came in. So.
No, I don't know that we've talked really about that today. So yes, so if you end up with significant amounts of obstructive sleep apnea, or you have both, and you qualify for both types of treatment, remedy can be used with almost any obstructive sleep apnea treatment, and that includes, you know, things from positional devices to dental devices to CPAP. It is where we don't want to use it is with ASV or with what we call BiPAP ST. Some of these special forms that have rates, because the rates can compete. But otherwise, we do have quite a few patients now on remedy with some low dose CPAP. It works very well. And then we do have patients with Inspire as well. We think right now we have about 24. They seem to be doing well, but they're not in my clinical trials, so I don't have a lot of clinical data to show. Hopefully, one of these days we will get them. But the patients report doing very well. But from a crosstalk, just like you would if you had a cardiac device, we know how to test those and program them with each other. And Mike may have more information because I think he has some people that have shared with him their experience with the two systems together.
We currently have in our support group, we have 8 individuals that have both Inspire and Remedy. They do coexist very well. Those people are very happy having both devices. They're maskless now, and that makes them happy, but they work well together. We've talked about, we also have people in our group that have spinal cord stimulators, some nerve pain stimulators. So we have a pretty diverse group, and I would invite any participants today that are interested to join the group. You can hear what others have to say about the remedy system, and you can ask questions and, you know, just browse the other responses that people have. So it'll give you a good feel for what's going on.
Perfect. Thanks, Mike. All right. I know we went a little over, everyone, but we've certainly come to the close of our allotted time. And if we failed to answer any of your questions, which we had a lot of great questions today, please feel free to contact us after the webinar. You'll find the patient educator's phone number as well as our email in the chat. You can always go to our website or the patient support page on Facebook that Mike hosts, where you can learn all kinds of things from past and prospective patients to help you make decisions and to learn more about this therapy. Again, I really want to thank our presenters, Dr. Germany and Mike, as always, for helping spread the information and their own experiences with this therapy. Thank you, everyone, for joining us. We truly, truly do appreciate your interest, and we hope you have a wonderful rest of the day.
Thank you, Diane.
Thank you, Mike.